everybody, we are going to start Unit 2 with obstructive cases. So in general, as a reminder, obstructive pulmonary cases are an umbrella term for the type of lung disease that makes it difficult to get air out of your lungs. Let's look at our first case. A 65-year-old male presents to the emergency department with shortness of breath. He reports that over the past 2 to 3 years, he's had a gradual worsening of his ability to exert himself because of feeling, quote unquote, out of breath. This has been acutely worse for the past week with a progressively worse cough that is producing a yellowish brown sputum. He reports coughing first thing in the morning, daily for about 4 to 5 years. He denies any chest pain, fever, chills, or night sweats. No history of lower extremity edema. So what are some of the things we're kind of crossing off the list right here at the end? So, just being out of breath doesn't tell you a whole lot about the origin of this patient's problem. Chest pain might be associated with something cardiac, like a cardiac ischemia. Fevers, that's kind of making us think about maybe a possible infection. Chills, going same thing. Night sweats can be kind of associated with fevers. Lower extremity edema. What kind of heart condition would go with lower extremity edema? That could also possibly lead to someone being out of breath. Maybe some congestive heart failure. So just kind of hearing what he doesn't have does help to narrow the focus. Of course, he is more than just out of breath because he does have this cough that's producing a sputum, which is really starting to point us more and more into the lungs. So these were the tests that they performed on this patient upon his admission. They did a chest x-ray, and as you can see written on the slide, it says the chest x-ray revealed that the diaphragm was flattened on both directions, which you can see here in the chest x-ray. I want to make sure that you can tell that it's flattened, so let's compare it to normal. Take a look at the normal dome of the diaphragm. You get this nice curve, right, that you can visibly see on either side. And then when you compare it now to the right, hopefully that flattened diaphragm becomes even more obvious to you. The full length of kind of blackness on the chest x-ray helps to illustrate that hyperinflation, that there's a lot of air in the lung and it might be pushing down on the diaphragm. They also did a arterial blood gas draw. So they took blood from an artery and these were the values. So I would encourage you to try to see if you can diagnose this patient's pH disturbance. And I have a little plug because just yesterday I got an email from a graduate from last year's class that just took the boards. And she said she had 4 acid-base balance questions on her board exam and wrote me like in all caps, "I cannot believe you drilled this into our head so many times," and I had 4 questions on it. She also said her cardiopulm section had the highest score on her boards. So if right now you are so sick of pH questions, I'm hopefully planting these seeds so deep that at the day of the boards, you guys nail these. So hit pause, see if you can figure it out. Do you have it? From the values that were observed, we've tipped the scale towards the acidic side. Since both of our 2 sides of our equation are both high, you have to say which of the 2 could possibly tip the scale this way, and it is going to be the respiratory system that gets the blame. So this is a partially compensated respiratory acidosis. They did some laboratory tests, and it revealed BMP was normal. So that's on that list, again, because heart failure symptoms can look a lot like lung symptoms, because when fluid backs up into the system behind the heart, it backs up into the lungs, and it can cause a lot of pulmonary systems. So they needed to rule out heart failure by taking the BNP values. They did pulmonary function tests, and they saw that his forced expiratory volume in 1 second was 58% of predicted, and the FEV1 to FVC was 0.62. And these PFTs represent a very classic pattern for an obstructive disorder because it is difficult to get your air out. So you have a worse exhalation values when you do your pulmonary function tests. Patients who have a diagnosis of COPD, they track their FEV1 very closely because it is the strongest predictor of mortality. When the patient is older in age, as their FEV1 decreases, mortality goes way up. So these are pretty closely monitored. From these laboratory tests, the patient's diagnosed with COPD with an acute exacerbation. So the main criteria that helps to define COPD is the FEV1 to FVC ratio. If it's less than 0.7, after they take a bronchodilator. So they do a bronchodilator, which should vasodilate and take away any acute spasming. They still can't get their air out quick enough. They're going to be categorized as COPD. So in addition to the FEV1 to FVC, the diagnosis is also based on the patient's signs and symptoms, what they're reporting, their medical and family history. They will look at all of the results of the test. So this patient's chest x-ray helped to make this diagnosis because you could see that hyperinflation. Sometimes they do chest CT scans to get more information on heart and lung and blood vessels. And then the ABGs really help to kind of illustrate how severe the patient is and might help the medical team make the decision on whether or not this patient might need supplemental oxygen. So hopefully you guys remember from pathophys that chronic obstructive pulmonary disease, COPD, is a diagnosis that really encapsulates two separate diseases. Patients with COPD likely have some combination of both chronic bronchitis and emphysema. And in pathophys, we spent a lot more time talking about how patients can present more like one more than the other, like have more symptoms of chronic bronchitis or perhaps more symptoms of emphysema. But clinically, almost every patient has some degree of both. Because of the shared kind of origin of these two disorders, they often come together. So chronic bronchitis is the presence of persistent, productive cough for at least 3 consecutive months in at least 2 consecutive years. So chronic bronchitis is very much descriptive on the symptoms, where emphysema is defined as permanent enlargement of the air spaces distal to the terminal bronchioles accompanied by destruction of their walls without significant fibrosis. Those are kind of the textbook definitions of those two. You have a little space in your notes if you'd like to draw along with me, but I'm going to attempt to do the one whiteboard challenge for both chronic bronchitis and emphysema. So come along, let's see if we can fit it on one screen, everything we learned from pathophys about these two diseases. All right, I'm going to draw a big pair of lungs on the screen, and I'm going to give one side chronic bronchitis and one side emphysema. Obviously, if this was clinical, they'd be on top of each other, but this will help with the visual. All right, so we have our large airway coming in and then splitting into our 2 separate lungs. We're going to just draw out some of the bifurcations that happen here. And ultimately, this will end with alveoli. All right, that's pretty good for one side. We'll do the same thing over here, get some branches coming off. And I'm gonna leave this like this for right now. We're gonna add to that side in a minute. All right, let's give the left side chronic bronchitis. Now, the generic cause of chronic bronchitis would be frequent and repeated exposure of your airways to an irritant. So often this is smoke, it can be pollutants that you're breathing in. So we'll just add kind of the cause up here as this frequent inhaled irritant is getting into the lung. In reaction to repeated exposure to an irritant, the lung is going to try to get better at trapping that irritant so that it doesn't get into the lower airways and cause potential infection. So one of the things that the body will do is it's actually going to cause the mucus glands to hypertrophy. So we'll make the mucus glands. Is purple too gross for a mucus gland color? So you get mucus gland hypertrophy. That's meant to be these purple circles here. You also get increased number of goblet cells. So, oh, I lost my pen. Goblet cells, I'll draw on the figure as kind of these little squiggly lines. So we see an increased number of goblet cells. So the body starts to make more of them. And for your memory, goblet cells are basically columnar epithelial cells that secrete the main component of mucus. So you get an increased number of goblet cells, you get mucus gland hypertrophy. So what does that ultimately lead to? Well, it leads to increased amounts of mucus, right? So I'm going to make the yellow kind of the layers of mucus that start to accumulate in the larger airways. In previous years, I think I showed this squirting some mucus. So there's some squirting mucus. So mucus accumulates. That's just to keep you on your toes if you would like to also draw some squirting mucus. The other thing that happens in response to repeated exposure to an irritant is you also get inflammation in the airways. And I'm not going to add that to our picture because I think you guys are familiar enough with inflammation, but with inflammation comes leaky vessels, which would accumulate in the airways and further complicate this obstruction to our airway. So the disease of chronic bronchitis is a response to repeated irritants that ultimately creates an increased production of mucus. And that gives the symptoms of a productive cough, that you cough up sputum. But in terms of airway dynamics, these yellow lines in the picture have decreased the diameter. Right? The size of the airway has decreased. And with a smaller airway, this is where we see airflow obstruction. So because the lining of the airways has gone through changes in its cellular structure as well as increased mucus production, there is now a smaller space for the air to move out of the lung, which can cause an obstructive phenotype. The other really problematic thing that happens is that when the mucus lands kind of deep in the lung, so I'm kind of drawing your attention here, you can get what's called a mucus plug. A mucus plug completely blocks that airway. And this leads to the airway trapping that comes with chronic bronchitis because it's completely blocked the airway, whereas in the upper, larger airways, it just reduces the diameter. So that's the chronic bronchitis, or sometimes referred to as type B COPD. Let's give the other side of this lung emphysema. emphysema are sometimes referred to as type A COPD. To tell this story, I'm going to draw just a rather normal alveolar ending here. And this will kind of be the origin of the disease, and then we'll give the lower lobes of this disease, of this lung, the full-blown disease, so you can see it kind of at the end. One thing I didn't draw into the left side of the lung, which probably should be there, but it would kind of messied up the picture, is within the lung parenchyma, there is a lot of structure to the lung. And within that structure, there is these alveolar tethers, kind of microfilaments that help hold everything together and open and kind of help pull the airways open. So I'm going to draw that on this side because it's going to be part of our story. So the beginning of this story is the same. In response to repeated inhalation of irritants, very often we're talking about cigarette smoke, but it can be pollutants and other things. You know, when we were on the left side of the lung, the effect was all in the upper airways. But if you breathe these irritants all the way in and it gets into these lower lung regions, the body is going to react with inflammation to try to attack and break down that irritant, because the body doesn't really know what it's being attacked by yet, whether it's a bacteria or a fungi or just smoke. So it has this big inflammatory response. So in response to irritants getting into the lower lungs, we see inflammatory cells showing up. So I'm going to make my inflammatory cells just kind of these green circles. And inflammatory cells, right, can eat and degrade things. And they do that by releasing proteases. Proteases help break down proteins. They do that among other things. The inflammatory cells release proteases among other things. So as these inflammatory cells are repeatedly called to the scene because this person is smoking on a repeated basis over many, many years, the inflammatory cells release proteases that break down protein. And it ends up degrading the connective tissue of the lung. So as these cells come in, it starts degrading the tissue of that area of the lung. In addition, with repeated inflammatory response, with the oxidative stress itself that comes from cigarette smoke, you get a lot of oxidative stress. So this is sort of my cartoon version of oxidative stress, which also breaks down the structure of the lung. So the disease of emphysema is an active process where the lung is trying to defend itself, and through its defenses, it ends up breaking down its own proteins. And one of the big proteins that gets broken down is elastin, which is how the lung loses that nice springy elastic recoil. So if this all happened many times over, what would ultimately happen in the lung is, instead of those nice grape-like airway sacs at the end, you get very enlarged, distended alveoli. The tethering gets degraded, so these are no longer being held together. The airways are not being held open because those strings have gotten degraded by the repeated inflammation. The disease of emphysema results in alveolar wall destruction. And when all those little individual grapes kind of coalesce into one big alveoli, this greatly reduces the surface area for gas diffusion, as this large airway sac now has kind of a fewer interactions with all the capillary network that was normally wrapped around kind of each individual grape. The loss of elastin means there isn't that nice recoil pressure when you go to exhale. You know, we all exhale passively because our lungs want to recoil. Emphysema has destroyed a lot of the structure of the lung that would like to recoil down, and it can get very challenging to get your air out. And we'll go further into that later in this unit. So these two sides of the lung in this picture represent the two kind of stories of the diseases of COPD. But of course, these lungs are most likely superimposed on each other, where the upper airways have mucus, the lower airways have distended alveoli, reducing the elastic recoil and worsening the gas exchange. Let's go back to the PowerPoint to look at kind of flow diagrams showing this same story in a different format. So on the next page of your notes, you see this flow chart. And it really just walks through the same steps that we just went through in my cartoony picture. That inhaled irritants are the initiating cause, with some genetic predisposition in the background that makes an individual more likely to react this way. But in response to repeated irritants, there's hypertrophy of mucus glands, increased number of goblet cells, and repeated activation of inflammation that leads to mucus hypersecretion and then that cough-producing sputum, which is a very classic finding of chronic bronchitis, where emphysema has the same kind of beginning, but now we're really talking about deep down in the lung, at the level of the alveoli, and the oxidative stress and the repeated inflammation with the excessive amounts of protease, this ends up destroying alveolar walls. And these two images, you can really see the effect of those tethers that would normally help to hold the airways open, get completely degraded and destroyed in the emphysema lung. So from that story of the disease, hopefully the clinical manifestations of these two diseases are kind of make sense to you now. Chronic bronchitis, you'd expect a cough with sputum production. Wheezing is evidence of a restricted airway. If you decrease the diameter, that's when you start to hear the wheeze, and that is a very classic finding of chronic bronchitis. Chronic bronchitis are patients that are classic hypoventilators. And this is kind of a not well understood phenomenon of chronic bronchitis. There's something about this condition that they can't clear their carbon dioxide out fast enough. And normally, elevations in carbon dioxide is what triggers us to breathe. It's what stimulates our respiratory control centers. But something about this disease and their inability to clear the carbon dioxide, the brain basically kind of resets and stops responding to the carbon dioxide. Kind of says, okay, fine, it's here. That's not going to be my drive to breathe anymore. And they switch and become hypoxic breathers, which means their blood oxygen levels have to get pretty low to stimulate the breath, which creates a clinical presentation of hypoventilation. With hypoventilation, it's very common, right, to see that hypercapnia. They're not clearing out their carbon dioxide. And then it's possible these patients will be hypoxemic as their oxygen levels are getting low, now that's the drive to breathe. So you can sometimes actually see a bluish color with these patients. And then secondary pulmonary hypertension can be common in chronic bronchitis because the blood vessels of the lung will vasoconstrict anywhere where there's not a lot of oxygen. And in your healthy lungs, that's a really good thing because that drives the blood to the areas of the lung that have plenty of oxygen, and it helps with our VQ matching. In this case, though, the problem's at the top, right? The mucus is blocking airway going everywhere in the lungs. So you get kind of a global vasoconstriction in the lungs. If you vasoconstrict the blood vessels, you can raise the pressure, meaning pulmonary hypertension. And so this is where the secondary pulmonary hypertension can come from in chronic bronchitis. Whereas emphysema, patients are still responding to those blood gases as a big drive to breathe. So these patients experience more dyspnea and more likely to be hyperventilating. And with emphysema, it's interesting because where that alveolar destruction takes place is kind of patchy. Like there's areas of the lung that still have pretty good alveolar integrity. So emphysema patients can actually hyperventilate their way into relatively normal blood gases because they can just breathe more into the areas of the lung that are not affected. So it's an exhausting way to be, but they can actually hyperventilate their way into relatively decent blood gases. But because of that, these patients are typically very cachexic, like losing a lot of weight because they have very high metabolism at rest, as they're basically exercising just to get their resting blood gases normal. Emphysema is where you're going to see a lot of air trapping, and so you can see that barrel chest, a lot of accessory respiratory muscle use because of the failure to be able to effectively use your diaphragm once you're barrel chested. When you flatten that diaphragm out, the dome has nowhere to go. So it's not going to be this really effective inspiratory muscle, which means they're going to rely much more heavily on their accessory respiratory muscles, which are not nearly as efficient and will really contribute to their sensation of dyspnea. You can also see pulmonary hypertension and emphysema, but it's from a different origin. The origin of pulmonary hypertension and emphysema is related to the destruction of blood vessels. So all of this inflammatory cells and oxidative stress is happening deep in the lung. And so right at the level of the alveoli, if you're destroying the alveolar wall, more blood vessels are wrapped around the alveolar wall. So you can destroy blood vessels as well. If you decrease the total volume in the system, you can get increased pressure in the pulmonary circulatory system and end up with pulmonary hypertension. On the next page of your notes, I just want to go through a little bit more on the air trapping specifically for each of these. And we are going to review the benefits of pursed lip breathing. So take a deep breath. There's a little bit more pathophys coming your way, but this is really important concepts and stuff that we educate our patients on all the time. So here's a typical alveoli where when you go to exhale, you create this external pleural pressure that squeezes on the outside of the alveoli, but also all the way along the airway. These nice tethers help to hold the airway open, and the elastic recoil pressure, along with any external pressure, if it's an active exhalation process, pushes the air out. As I already mentioned, in chronic bronchitis, you can get air trapping, but in this case, it's more to do with the blockage or a mucus plug that blocks the small airways and prevents air from leaving. Whereas with emphysema, the destruction of the proteins and the connective tissue of the lung reduces the total elastic recoil because the walls, right, these arrows are meant to represent less elastic recoil. The arrows have gotten smaller. The tethers are now broken away and they're not holding the airway open. So now when the pleural pressure comes from the outside and squeezes on those airways, they collapse. And the process of active exhalation actually collapses the airways and leads to air trapping. And this is a huge problem for our patients because as air gets trapped, there's less space for a nice big fresh breath of air on the next inhalation. So if patients are constantly holding more and more air in their lungs, there's less room for a fresh breath, and they get more and more dyspneic and out of breath and not getting enough oxygen. Where if we can help them get more air out on the exhalation, this disease really does not have a problem getting air in. Because when you inhale, the process of inhalation pulls outward on the lung and it helps to open up the airways and air can come into the lung. But we have to get it out first so there's space for the fresh air. And that's where we get into the concept of pursed lip breathing. Since you've got a blank space in your notes, I'm just going to draw this out so you can write it with me, so we can kind of walk the walk and remember this concept from pathophys. So I'll just draw 1/2 of the lung here. And we'll draw this as just one big alveoli. So in order to exhale, we have to create positive pressure in the alveoli. And I'm just going to draw out the emphysema lung. Am I spelling this right? No, I'm not. We're just going to draw out the emphysema lung when it's problematic. When you go to exhale, there should be elastic recoil of the wall of the alveoli. In emphysema, this is going to be reduced because we don't have that good spring back of the alveolar wall. So let's give the elastic recoil just like a +2. But you can create positive pressure in the alveoli by pushing, right? You can actively exhale. You can take the accessory muscles of exhalation and squeeze from the outside and push on the lungs and generate positive pressure that can be added to that alveolar pressure. And let's try giving +20 to the muscles. With muscles pushing 20 and elastic recoil giving you 2, you have +22 millimeters of mercury pressure above atmosphere to drive air out of this lung. So that is a good thing. That should help us get air out. Of course, this is an emphysema lung, so they're going to run into trouble because as the air leaves the lung, some of that pressure gets dissipated as it overcomes the resistance of the airway. So 22 becomes a +20, and it becomes a +15 as it heads out. Well, as the airway pressure decreases in the airway, the external pressure of the muscles stays the same. And you don't get to just squeeze the alveoli, you're squeezing the whole thing. So that 20 millimeters of mercury pressure is on the outside of these airways, right? 20 millimeters of mercury is pushing all the way along on either side. Well, as you can see at this point right here, the pressure inside of the airway is less than the pressure outside. So what's going to happen to that airway? Well, the pressure is going to push inward, right? In fact, it'll completely close that airway off because we're in this floppy part of the lung or floppy part of the airway. It's not supported by cartilaginous rings. There's nothing to hold it up open if it's not pressurized from the inside. So at this point, we have now trapped all of the air distal to that collapsing point. So the concept of pursed lip breathing, I'm just going to erase this arrow so I have a little space. And maybe redraw this so that it's kind of coming in because it's 15 here. Pursed lip breathing takes the output and decreases the diameter. So you narrow the opening to let air out. And the best way to remember this is to think about putting your thumb over the top of a hose. If you decrease the diameter as the water is trying to get out, you will build positive pressure behind your thumb. And that's what pursed lip breathing does. It builds positive pressure. So you're adding positive pressure to the airway. So if it was collapsing because the external pressure was greater than the internal, and you could add more positive pressure, you might be able to pop that airway and keep it open longer to allow air to leave. So when we teach pursed lip breathing, it's really helpful to explain to patients why making your airway more narrow can help keep their airways open, because one of their big problems is airway collapse. And when you teach pursed lip breathing, you want to instruct them to not push their air out as hard as they can. You have to explain to patients, the harder you push, the more air is going to get trapped. So it's better if you can decrease the muscular effort and allow a very long exhalation. Because if the external pressure is a little less and you're adding positive pressure at the top, you can keep this airway open and prevent some of the degree of airway collapse. And if you get more air out, there will be a greater potential volume for fresh air to come in. Make sure you have a good working understanding of this. This is very effective with patients. I get a lot of emails from people in their first year or two out, from all walks. Not everybody who goes into cardiopulm, but people who use some of this stuff in different settings will write to me. And this is actually one of the concepts that people it's more likely that I'll hear from our PTs that once they're out in the field are like, oh my gosh, this makes a huge difference. And some of my coworkers didn't even know why it worked, and they were teaching it, and I taught them. And this is one of the things that seems to kind of circle back, that people really end up using and explaining to patients and making a big difference. So rewatch that segment or check in with a friend, try to explain it to each other. This is a good one to kind of know in your bones so that you understand how this technique really works. So back to our patient who was diagnosed with COPD. This was the drugs that he was given. So he was given a beta-adrenergic agonist and an anticholinergic bronchodilator and corticosteroids. Now, I try to sprinkle in this class some review of meds, just because you're getting close to board time, and pharm was a year ago, and there's not another time really that you get to re-hit this stuff. So I put these charts in your notes that you can see there as a means to help you kind of dust off the cobwebs and remember what some of these drugs do and why they're on board. If you're someone who's not as comfortable with the pharmacology, just lean back on what you do know, and it can give you some confidence. So beta-adrenergic agonists, what is this saying? Even if you don't remember anything about it, well, I know that beta-adrenergic receptors, adrenergic sounds like adrenaline. That must be my adrenaline receptors. Adrenaline goes with the sympathetic nervous system. So a beta-adrenergic agonist, and agonist means like I'm trying to act like that guy. This must be a drug that acts like the sympathetic nervous system, which is what it does. It activates beta-adrenergic receptors. So with a lung patient who's given this drug, it's helpful to remind yourself of what the reaction of the sympathetic nervous system is in the lungs. In the lungs, it causes bronchodilation. It relaxes the airway smooth muscle. So it's exactly what this drug does. It helps a patient with COPD because they have reduced diameter of their upper airways. This drug will help increase the diameter. Now, when you go to look at some of the major side effects, they make sense if you also think about what a drug that's pretending to act like the sympathetic nervous system would do. It's going to stimulate the heart. So one of the side effects is sinus tachycardia, increased heart rate. It can cause some cardiac rhythm disturbances, can mess with the heart a little bit, and it can end up giving you tremors, right? Like activating your muscles and getting you all kind of revved up. That's the sympathetic nervous system. Anticholinergic drugs block the cholinergic receptors. This one might not be as intuitive for you guys, but cholinergic is kind of coming from the name acetylcholine. So it's the main neurotransmitter of the parasympathetic nervous system. So this drug is trying to block the receptors that respond to the parasympathetic nervous system. So what would the parasympathetic nervous system do? Well, if the sympathetic dilates, then the parasympathetic must constrict. So this drug is blocking kind of a constrictor response, which would then lead to bronchodilation. So this patient is treated with a combination of these two. They're kind of trying to hit the system from both sides, stimulate the sympathetic, block the parasympathetic, as a goal of increasing the diameter. The last one on the list is the steroids. So the steroids are the anti-inflammatory, kind of keeping in mind that steroids are going to really act like cortisol, so it can lead to muscle wasting and bone loss. If you're blocking the inflammatory response, you're more susceptible to infection. There's also a risk of hyperglycemia for patients who have diabetes. But this drug is on board because of the inflammatory nature of the COPD. Block the inflammation, you should be able to help open up the airways. So this patient was referred to physical therapy. Let's do a chart review and see if we would see this patient. So past medical history is unremarkable outside of having an appendectomy. He lives in an apartment with his wife and has a 40-pack year history of smoking. So don't mind my subtle messaging on this slide. Quit smoking now. So cigarette smoking is implicated in about 90% of COPD cases. So quit smoking now. Spread the word far and wide. All right, so you go in to see this patient. Upon inspection, he's alert and oriented ×3. He's sitting up in bed but leaning forward, and you notice some cyanosis at the lips. So right when you walk in the room, you're taking in the full picture of a patient that has a posture that might be kind of suggestive of difficulty breathing, and then you're actually seeing evidence of blueness, which would tell me I'm concerned about hypoxemia. You don't see any visible signs of excessive accessory muscles, no JVD noted, jugular vein distension. That would be a sign of heart failure. Very low respiratory rate. He's breathing 8 breaths per minute with this prolonged expiratory phase. His inspiratory to expiratory ratio is 1:4. His BP is 144/88, and his heart rate is 98. On a 0 to 10 scale, he rates his dyspnea a 5. He has got normal extremities, no signs of edema, and no signs of clubbing. Clubbing, again, would be kind of a sign of chronic hypoxemia. You take out your stethoscope and you listen to his lungs, and you hear wheezes and crackles bilaterally. Wheezes would suggest a reduced diameter of the airway, where crackles can either be collapsed alveoli reopening on inhalation or fluid in the lung that's moving around. Heart auscultation, you hear reduced heart sounds. Do you know why a patient like this would have reduced heart sounds? The heart is kind of hidden under all that air. So a barrel chested, it's hard to hear through all that air because sound doesn't travel as well through air. So it can be really hard to hear heart sounds. Normal tracheal position kind of lets you know there's not something unilateral going on, a change in pressure or volume on one side or the other that would have deviated the trachea. His breath pattern is being initiated in the upper chest with decreased lateral costal expansion or diaphragmatic excursion. Very common breathing pattern when you have that flattened diaphragm. We're going to get this patient's walking. So you take their resting values were 144. We have those from above. 144/88, heart rate 98, respiratory rate 8, and he was statting at 92%. You did an evaluation. He was able to walk 150 feet with a wheeled walker and contact guard assist, but you had to stop walking because he was getting very short of breath and he desatted to 86%. When he sits back down, you retake vitals, and you can see that recovery is starting to happen already, especially on his O2 sats. So what would you do with a patient like this? From a PT perspective, what would be some appropriate goals? So we're just going to kind of list them here. Some of these we've already talked about in lab, some of them are still coming. But a patient that has this productive cough and a disease that ends up having hypersecretion of mucus would really benefit from techniques to manage secretions. So you can teach this patient ways of clearance, breathing techniques to help clear that might make a huge difference in terms of their tolerance, their ability to be successful in other functional goals. Teaching techniques for his dyspnea and shortness of breath, going through pursed lip breathing, encouraging him to use that, at the earliest signs of dyspnea or whenever he does something with a little bit more activity. You can do paced breathing to help regulate breathing rate with activity. And then really teach this patient positions that relieve dyspnea. Give him some tools in his toolbox that when the demand of breathing exceeds his ability to match, he can get himself into a good posture position to help increase his ability to breathe. Energy conservation, talking about breaking tasks up and making his room arrangement, his house arrangement more appropriate, because he might not have as much energy, and you can be successful if you decrease the total energy cost of an activity. And then talking through the self-management of his disease, monitoring his weight, keeping an eye on secretion color. That can be the earliest sign that it's starting to develop an infection, and the earlier you can act, the better. Really talking through the role of exercise and strength gains and how that might help this patient. And then always, always, always including some conversation about smoking cessation. So you would see a patient like this maybe about 3 days before he was discharged to home. So this patient tolerated treatment well and went through a lot of the interventions related to those goals well and was discharged to home. So we'll end this video series here. We'll pick up another COPD for case number 10 to go into a little more detail on some of those aspects. Hope you guys are having a great day. Bye-bye.